Good morning. We are counting heads right now. I think we have 10, 11 people here. We do have a quorum, so I'm going to go ahead and call the meeting to order. We have 7 people attending remotely on the screen, so if you can put initials with names, we can do that, and we'll go ahead. So I'll call this meeting to order. Number 2 on the item on our agenda is approval.
Can you pull your microphone closer? Apparently there's some difficulty across the way. Much closer. Get closer.
Hello. Hi, good morning. I will go ahead then, and item 2 is approval of December 9th, McLean County Behavioral Health Coordinating Minutes. Motion
Second.
by Member Reese, second by Member Taylor. Any comments or questions, additions, or corrections? Hearing none, all in favor, please say aye.
Aye.
And opposed? Okay, the motion's passed. We have a new member joining us today. Esteban Lozano joined State Farm in 2020 as an HR specialist. He comes highly recommended to represent State Farm with us. He assumed the role of HR&D executive, overseeing the talent strategy function in 2021. Esteban received a bachelor's degree in economics and business administration from Illinois Wesleyan and a master's degree in management and strategy and entrepreneurship from the Kellogg School of Management at Northwestern University. Thank you for joining us, Esteban, and welcome. Would you like to say anything more about yourself?
Well, Mr. Chairman, thank you for the warm welcome, and I look forward to working with all of you and meeting you. I would say that most of my adult life I've been in and out of Central Illinois. Before Bloomington, the last 5 years, I spent time in Peoria. So I look forward to how I can contribute personally and how I can represent State Farm in this role.
With Caterpillar for what?
About 17 years.
17 years.
Yeah.
Well, welcome, and I'm sure you'll get to know everybody. We could go around and introduce ourselves very quickly. I think you can see who they are, but let's do it very quickly.
David Taylor. I'm also a Wesleyan grad with economics and business administration degrees. So welcome, Esteban.
Nice to
I'm
meet
trying
you.
to get into my computer.
No, good to meet you. I'm glad, I'm the alderman for Ward 2, and I'm always glad to have a new person because now I'm not a newbie anymore.
I'll pass the baton hopefully soon.
Good morning, Matt Mullenhauer, Chief Clinical Officer at Chestnut Health Systems here.
Thank you.
Good morning, I'm Stephanie Barish, and I'm the Director of Therapeutic Services for the Center for Youth and Family Solutions.
Susan Schaefer, Chair of the Health Committee of the McLean County Board.
Good morning. I'm Colleen O'Connor. I'm the Executive Director of the local chapter of the National Alliance on Mental Illness. I also run the county's Youth Suicide Prevention Program, and I'm a Wesleyan grad. Welcome.
Good morning. I'm Sonia Reese, and I represent the McLean County Board of Health.
Hi, Teresa Prosser. I'm one of the nursing directors at Carl Broman Medical Center and work with the behavioral health service line, so addictions and mental health. So, welcome.
Anyone else? Okay, well, thank you. I'll try to speak into this mic. Let's go on for our program this morning. Our first is item 4A, Susan Schaefer, our NACO, National Association of Counties Leadership Network update. Susan, you have the floor.
Thank you, Mr. Chairman. You can go to the next slide. So this slide is just a reminder of what the Familiar Faces initiative is and the Familiar Faces Leadership Network. I'm not going to talk about this, and you all can read that. Go on. So this is going to be a very, very broad overview of a very broad overview that we received when we went to Bexar County, Texas. So if you don't know where Bexar County, Texas is, that's San Antonio. So there's a lot of things that are kind of sort of the same, and there's a lot of things that are different. So if you can imagine McLean County having 2 million people, because it's physically about the same size. So that was kind of a interesting little stat there. So their Familiar Faces initiative actually began with healthcare. If you want, and then added the jail, where ours kind of started with the jail and issues with the jail population. So then there's some differences. We are Medicaid expansion, they are not. So they have a lot of uninsured individuals. And then they realigned their mental health code to be with HIPAA, where Illinois obviously has a much more restrictive code for confidentiality. Go ahead. So they have two groups, well, they actually have more than two groups, but the thing called STRAC is what was legislated, and it was, this, like I said, it's all about healthcare, for trauma. And so Texas is divided up, I think, into like 8 of these different regions. And as you can see, it is healthcare, it's hospitals, it's EMS, but it's all about trauma for people that have access to that trauma. And so underneath STRAC, there's many different groups. If you can imagine that they're working with 2.4 million people, there's many groups, and STIC, lots of acronyms. We learned a whole bunch of new acronyms when we were there, is a division of STRAC. And they started in 2015, and that was part of the jail problems, because they were finding that there were people in jail. They were finding that a lot of the people had using a lot of the services, but it still was focused on healthcare. Still was healthcare driven. But they realized that there were ineffective, utilization of their services. Kind of sort of what we found here when we did our needs assessment and our best practices back in 2013 and 14. So they also have various work groups. So just kind of like what this group is has various work groups, and we're going to have more work groups. But STIC is actually what I would consider a combination of BHCC and CJCC. So like some of the people that are at our table wouldn't be on their table, but there would be others, So it's kind of a combination of those two. So their work groups, they have different kinds of work groups. They have ones on data. They have ones on the system of care. They have on social determinants of health, that kind of thing. But they're all held accountable by shared goals and shared metrics. So I think that's, all I wanted to say on that one. Go ahead. So back on the first slide, if you looked and remembered that this is all about data sharing across systems and utilizing data to improve outcomes. So they created a database of 6 years of population health data, only of their safety net population, because they were spending a lot of money on that. And so they had 6 hospital systems, 3 clinics, EMS, corrections. All they did was look at who was booked into the jail. So they did not look at law enforcement numbers or anything like that, data. And then Haven for Hope, and I'll talk about Haven for Hope in a minute. So they looked at that, and they found that there was a lot of overlap. And if you remember, and you go back to our mental health action plan and talks about information sharing throughout the crisis system, that there is a lot of overlap. We don't know who is duplicated, who's only getting services here, who's getting services here, who's getting services in multiple places. I mean, when you have 6 hospitals, those individuals can be going to various hospitals, and so they're not, you don't have a unique number, you don't have an N, which is their big takeaway on this session when they talked about this, is that you don't have the number, to actually work on things. So but they also looked at not just the primary presenting as behavioral health, they also looked at as a secondary, because there were a lot of other chronic conditions that were actually the primary presentation at the hospital or through EMS, but the mental health was an underlying cause of that too. So what they found was the population was a lot higher than they thought it was on the familiar faces. And so 30% of them obviously were also in the jail. So then what they did was they took that data and they were able to create targeted systems or targeted programs to address some of the issues that they found. One of them that I thought was pretty interesting, they had 800 jail bookings, and then their Haven for Hope, which was their homeless shelter, had 1,200 EMS runs. And when they started. So they had a targeted program because when they looked at the data, they realized that a lot of the EMS runs and the times they were called out to the homeless shelter was for minor medical type things that can be addressed in a different way. So they created an acute care station project there. And so with their 1,200 EMS runs, they had a 66% transport rate at that time. So then when they put this care station in there, they reduced their ED visits from 807 to 439. So that's like almost half of the number of ED visits. So then they looked at, they don't call it cost savings, they call it cost efficiency on that, and it was like almost $900,000 to do this. And obviously, it didn't cost $900,000 to implement this care station. So, and if you think about it, a regional office with their Bridge Academy, they know how many people, how many kids are not in school because of mental health, so they could create a targeted program. And that's what Bridge Academy is. So we kind of do that a little bit, but we don't have all of it. And they also did some intensive care programs for those really high utilizers. And what we've done so far with the FUSE program, it's just the homeless and the jail. So we don't have the healthcare. So we don't know how many in the healthcare field area are needing those intensive services. So Haven for Hope. This was actually really impressive, but it probably would be more applicable to Cook County because we don't have 2 million people to have this kind of population. This is pretty impressive. And then there's another slide I have with a picture of the campus. But the one thing on this slide I'd like to point out, which I thought was really intriguing, is that last bullet point. When they have all of these partners, they have 70 of them on site. So a person who needs services that's in the shelter there can go into the building. They can be warm handoff from different needs to different agencies, working together in collaboration. And so, I thought that was really intriguing. So we wouldn't have a shelter, but what about, and maybe this conversation for the future, having something like this? We have a lot of resources. We have a lot of agencies that are not at this table. So here's an idea that they have that may or may not, because we have to adapt. We can't just downsize that kind of shelter, because I don't think it would work here. But there are some things that maybe let's tweak that, see if that would work. So that was just kind of what I wanted to point out on that slide. And then this is a picture. This actually, the location was actually a state hospital that they had torn down, and so that was kind of, I think, donated to them. And it's pretty impressive when you go there. Okay, so, and then this is just what happens outside the gates because it is gated. And inside the gates, there's supportive housing and sober housing that's based on the Oxford model and things like that. But this is what's outside the gates. They have like 6 or 8 FQHCs in San Antonio, and they have one right outside the gates so that they get their health care right there, and they don't have to go very far. So, okay, next one. And so how they get funded, because everybody wants to know, how do you pay for all of this? STIC was obviously legislated, so they get a lot of state money from that. But then the providers, the hospital systems, and philanthropy. Basically, actually even for Haven for Hope, they're about 60% federal, state, and local, and the rest of it is philanthropy. So when you look at Haven for Hope, they had $40 million seed money to build that campus from a very wealthy oil magnate. And we don't have any of those billionaire people in McLean County, at least I don't know of any, that would do something like that. So they do have some advantages, I think, that we don't really have in that. But that's how they got that started. And like I said, 60% is federal, state, and local, and the rest of it's obviously a lot of people that like to donate to that cause. So next. So then they gave us a presentation about their NAMI group is very active. Obviously, it's very large. And there's a program called Bridges to Care. And it was based off of one that was created in St. Louis. And it is faith-based. It draws the faith-based community, and you try to educate and train the faith-based community. And that is something that we discussed and was in the original Mental Health Action Plan, and I think it still is in the update, on getting the faith community involved, because there's a lot more trust in that faith community when people can go to someone in that area. So, and I guess this is a evidence-based type thing, and there's some modules that they get trained, and then those individuals really work with people. So a little bit more different level of care, kind of thing. So thought that was pretty interesting, and maybe something that we want to look at, whether it's through BHCC or whether it's through the CHIP and the CHNA group to get, maybe something working on that. So somebody step up and look into this program, because it sounds like it's a pretty good program. And that actually reduces stigma and things like that. Next one. So I had said that BHCC and CJCC was kind of the combination. And so there were things that I also reported on to CJCC last month, because there that overlap there. And excuse me, one of the common challenges is that they lack inpatient beds. Yeah, well, we know that too. They actually said they had 100 empty beds because they have no staff in their state hospitals. And so the average wait time in jail for a bed is quite long, and actually it's longer there than it is here. And they also have a lack of private psychiatric hospitals. And one thing I want to also mention is that this is all focused on adults. This does not have anything to do with youth. So when we look at our youth group, it's kind of different from what they're doing. So they also have an alternative response team, which was created in 2020, and that is only the city of San Antonio. And it's really not what I would call an alternative response team. It's one of the co-responder models. There's various flavors of co-responder, but that is what they do. And they used to have, and I'm not sure if they still have, CIT teams in their law enforcement, and that would go out on mental health calls. And I don't know if they still had that years ago. But anyway, the co-responders, there's some similarities to the legislation in CESA. And so then they also have cite and release, which is similar to Safety Act. So there's a lot of overlap here. And then they have this really nice intake for the jail, and they actually divert individuals immediately. They really do have a prosecutor and a public defender and a judge available 24/7 to divert people out of the jail before they ever get in there. So that's pretty cool, but not necessarily reasonable here, because we wouldn't have those kinds of numbers. So and then they have a reentry center at the end of the jail when people leave jail to get them into services and that kind of thing. So that is pretty much, I only have 15 minutes, so very
Okay.
high overview. So if anybody has any questions, I'd be more than willing to ask. And there's still some follow-up that I'd like to do on some things, just because I think that more detail needed if we want to look at that kind of thing. So, Sonia.
Great report. This sounds fabulous, but fabulous for a city that size. If you could identify 2 or 3 things that are the takeaway that you think we could implement here, what would they be?
I'm all about the data sharing. And you don't, until you know N, you can't really create targeted programs. You really don't move forward well. So the data sharing, and so I think that eventually we're going to have a data sharing work group
Okay.
to do that. Like I said, the intriguing part of the all the providers under one roof, like I said, that way it's much easier to do care coordination, maybe case management, that kind of help people navigate the system. That includes social determinants of health. Third takeaway,
That's okay.
yeah, those are pretty big takeaways.
Those are
though.
big.
Yeah.
Sounds like we're working on data.
Yeah, and there were things, and they're much farther ahead. I mean, if you think about it,
Right.
They started this in, 20 years ago. Haven for Hope was built in 2010, so they've had a long time for the system to evolve and work through issues and stuff like that.
Thank you.
Stephanie, you have a question?
So you mentioned that their single group looks like a combination of our BHCC and CJCC. Is there a need for the makeup of the group working on these issues to be blended, or for this group makeup to change, so that the entire system is encompassed in that one conversation?
Possibly. Yeah, because when you look at the data, when you're going to need law enforcement, you need the CJCC side of it, then you have provider side, healthcare on this side, to get some of that information, you do have to have that. Now, whether or not we need to create another group, I don't know, or combine groups, but when it comes to a work group, I don't really see a lot of this group here being in a work group for like data. But then again, I don't see a lot of CJCC individuals if you're looking at something like putting everybody under one roof kind of thing. So there's that balance, and I think the work groups can probably address that issue to a point, but it could be something for further conversation, but that's up to the chairman.
How did Texas have data sharing across the systems? Because we still have the problem of not getting, you can't analyze anything and decide anything if you don't have data, and you can't get the data from our hospitals, healthcare system here. Is it a law? What holds us up every time?
This is, and I don't know if it's a law there or what they did. When they created those regions, they have actually one place where all EMRs are. And so there's this registry, and all EMRs are there. So they can then obviously analyze that part of it. Now, we didn't really get a lot of information on, other than they get information from the jail, but they didn't talk about counts on law enforcement or anything like that. So I don't think that they have that data merged in, because like I said, this was really focused on healthcare, because healthcare was driving the familiar faces because it was costing healthcare so much money. So we're trying to marry
We have law
them.
enforcement data,
Pardon?
but we do have here.
But we have law enforcement, yes.
So
we have the opposite, we have the whole
Yeah,
criminal
okay.
justice side data. We don't have the other side. So that's what I said. There's same and different, kind of things, so.
Okay, thank you. Anyone
Anybody
else?
else?
Well, we should move on then.
Thank you.
Thank you, Ms. Schaefer. Frank Beck is here from Stevenson Center. Appreciate you coming, and has a presentation on data tracking across the systems, which fits right in.
Hi. Thanks for having me, and thanks for coming up out so early in the morning on a Friday. So the Stevenson Center has been involved with the Criminal Justice Coordinating Council for 10 years or so. And it started with the jail overcrowding and managing data for the CJCC. And it's good to see that the two groups, BHCC and the CJCC, might start to collaborate on data and in order to answer your questions. I'll be clear. We don't drive the conversation for the CJCC. We listen, the Stevenson Center listens to what the CJCC is asking, is talking about, and then we think about what data is already present that can help answer those questions. And we can't answer all the questions because we don't have access to everything. And so that'll be our approach here, is to listen to the BHCC and then try to answer what questions you have for your own purposes, rather than driving a conversation. So with respect to mental health, the jail CJCC wanted us to do some analyses of what are the patterns of mental health issues in the jail. And this has evolved over these 10 years. And so I'm going to provide a brief view of that, and I'm going to provide some views of what's happening over the last couple of years in the jail, and then what's possible will be the last slide. So with respect to mental health, without access to diagnoses in the data, there are 4 indicators in Aegis regarding mental health. One is the police officer puts a mental problem risk label on someone as they're booked. So check marks, there's somebody there who the officer is saying has a mental health issue. The second is self-report at the point of booking. So someone who is coming into the jail is saying, yes, I have a history of mental illness. Yes, I've attempted suicide. Yes, I've hurt myself, previous mental problems, and so forth. So that's the second, officer and self-report. The third is that the jail staff will place someone in a special circumstance. Labels in the system are low functioning, mental health, there's a segregated space. Protective custody, something I'm going to use words from Law and Order more so than what I actually from working in a jail. So jail staff place someone somewhere. And then the fourth is caution codes. In the system, there's known gang member, there's known mental illness, there's known suicide, and these are labels that are put onto a person and they stay. They don't come off for the purposes of cautioning someone in the system that there might be an issue. So those 4 are what we've used to show the patterns of mental health issues within the jail. And then after all of that, I did the wonderful scientific question of calling a member of the jail staff and saying, 30% of the jail has a mental health issue. Does that sound right to you? And the answer was, yes, that sounds absolutely right. So without diagnoses, that's as good as we can get with Aegis. So next slide, please. This graph shows a percent of bookings with mental health issues going way back in history, 20 years. And you can see that there's an increase in the percentage of persons walking in the door that have mental health issues and a decrease in the percentage of those who do not. No surprise. This is by sex. So clearly, we know that the jail is more populated by men than it is by women, and so the blue line is showing just that pattern, and that it hasn't changed much over time in terms of the sex ratio and of those who have mental health issues. It's just stayed the same. Go ahead, next slide. This is length of stay. And as the increase over time may at first concern you, and let me be clear, the men is the blue line, the red is women. And so length of stay increasing and red flags go up. Let me say this is primarily driven by the jail and law enforcement in the community not housing misdemeanants as long as they used to. So the length of stay has increased because the percentage of the jail that's being used for felons relative to misdemeanants has gone up. So this isn't necessarily the red flag that it might look like, but it does tell you length of stay. So we're talking, 15 days, 30, 35 days for men on average. And again, that's being driven by felons. Please, thank you, by the way. Instead of me just waving my hand, this is length of stay for those with mental health issues and those with not. And so the red line is those with mental health issues, and the blue line is those with not. And it's pretty much the same, and it's going up again because of felony issues. Okay, next slide, please. This is the slide that matters a lot to Cassie, because this is the budget. Total bed days are how many persons are in the jail for how many days. So you're in there for 10 days, that's 10 bed days. And the jail has so many bed days available. Those who work in healthcare might use the same term, I'm not sure. We're at 50-50. So of the total bed days being used, half are now those with mental health issues. And if this group can do something to decrease and help people receive care in some other way, jail, if people can, if there's a redirect system in place, and hopefully data can help figure out how to, or we can at least track what's been happening. Next slide, please. Okay, recent history. In the last 3 years during COVID, 4,470 bookings into the detention facility where there's been an indication of this mental health issue. So 4,470 separate bookings. Some of those are the same people. A third of those are women, and a third of those are African American, even though the county is 8-9% African American. 3,000 of the 4,400 included a drug charge. So in terms of a connection between mental health and drug use, this is possible in the data, but you have to go rely with what Aegis has. Aegis has what is somebody charged with, and Aegis has one of those 4 indicators of mental health. And so the extent to which there's an overlap, you can start to see it that over half of the 4,400 bookings involved some drug offense. The average length of stay is 21 days, but 806 of the 4,400 were in and out within a day, and 1,600 spent one night. So if you add those up, you're at 2,400 out of the 4,400. So you're over half are in and out within a day or less.
Frank, I just want to clarify, if I may. You said that more than half had a drug charge, but that says did not include a drug charge. So I'm just trying to clarify which it is.
My bad.
Okay.
I was reading my sentence incorrectly. Thank you. Thank you for clarifying that, David. So 3,000 did not include a drug charge. My bad. Sorry for the confusion. Over on the left is a chart that shows charge severity, and you'll see that of those bookings 2020 to 2022, of the 4,400, 32% are misdemeanors. And so the other 2/3 are DUI and traffic, but primarily felony on the other 2/3. The no charges filed are people who are booked, and at the moment, there's no charge filed, or they're booked on some civil matter. So that's the 10% down at the bottom of that table. Next slide. What's possible? So we can disaggregate these mental health patterns even further by sex, race, age, charge severity. We can look at bond amount, which we know is in flux in the state, and more. We can merge Aegis data with that of other programs, social service agencies, so forth. The question of how is sticky. Aegis uses a person ID number, but there's other data that I don't see, which is name, but there's a way to merge some information. Kevin, we're going to have fun talking about that. We can examine the co-occurrence of drug-related arrests and mental health issues. We have been working with the CJCC on juvenile issues. For those who, say, had juvenile offenses and are now 18, and what's their what's their interaction with the justice system after they're 18. Indeed, we're finding some people, and we're actually going to start interviewing them, persons who had 3 or more bookings as juveniles and have never been in the adult system. And so the question is, what happened and what might have worked? Our job, again, is to listen to your needs, and we look forward to the longer-term project of integrating behavioral health data with Aegis, and again, helping you answer your questions. I hope I was under 15 minutes. Questions? Good to see familiar faces and hopefully new faces too.
Thanks, Frank. Any questions? Anyone?
Sonia?
Ms. Reeves?
I share the concern with the ability to connect with the healthcare information and the jail, and making any overlap in as much as the identification systems are not the same, so we don't know who we're dealing with. Are there other places that are similarly situated to ours that have figured out how to bridge that?
I don't know as much as, say, Susan does with respect to San Antonio.
Yeah.
And how that's happened elsewhere. I do know that there are, I believe, that our county has worked with Aegis and HMIS, is the homeless shelter system, and has been able to merge data between those, which then informed Fuse. And I don't, was that through NYU or was that through some other?
No, that was through the Corporation of Supportive Housing and the University of Chicago. That tool was developed specifically for Fuse-type programs.
Yeah.
So there are, this is going to kind of, it blows my mind when I think about it. There are AI
Abilities?
software abilities at NYU and Chicago, and I don't know of where else, and if it's moving into the private sector to purchase something, but trying to match John Smith, birth date 9/30/66, with John L. Smith, birth date 9/30/66, or individuals who change their last name, have aliases, so forth. There's AI technology that now allows matching data across names. And I'm not that person, but I know how to look at it and evaluate it and decide whether or not it's useful.
The HIPAA rules have been a factor for us all along, and I'm always interested to see how other places have found a way to, I won't say circumvent, but work within HIPAA rules and still collect the data and protect the individual's identity.
My
Hospital people,
my
that's our challenge.
Right. So my agreement with the county, this Illinois State University's agreement with the county, I don't see names. I see person IDs, and I don't even see date of birth. I see year of birth. That's one of the ways in which private information has been held, and then we've been able to do all this analysis within there. And so I don't need to do this. We don't need to know who somebody is. But I understand that once you know this piece of information and this and this and this, you can probably figure out who somebody is, and that has to be suppressed. But I think there's a way to figure it out.
Okay, thank you.
Susan?
I kind of want to elaborate a little bit on that too. In San Antonio, one of the things that they did talk about in the STRAC meeting was the amount of work that it took to get agreements and things like that. There's a lot of legal stuff but it can be done. I mean, it can be done. We're going to Johnson County, Kansas next month, and they also have, actually I met with them a couple of times in the past on their data sharing, and they actually have behavioral health information. So I'm going to investigate that a lot more on how they do that. But it's a lot of legal issues. But it can be done. It's difficult. It takes time. But it can be done. And also, one of our goals in the Mental Health Action Plan is to work on changing some of the confidentiality rules in the Illinois Code. So that would help us immensely to do this, which is why Texas did that change a long time ago. They realigned it with HIPAA, and Ohio recently did that too, is because HIPAA is less restrictive than our code, which makes this kind of thing much more advantageous. And if you look at anything any documentation on mental health and a lot of other things, other topics, it's data-driven. And you have to have that data to make decisions, both for the client and also financially, So it's work, but it can be done, and which that data subgroup is going to be very interesting.
Taking it to another extreme, Frank, you ever get a chance to look at Charlotte, North Carolina's system, which I believe is run mostly faith-based. I don't know where the power is in North Carolina or in Charlotte or how they get that information, but it's run almost from a voluntary, supposedly voluntary system. It'd be interesting to see the other extreme of that too, to get that kind of a data system going. Thanks. Anyone else?
Chairman Kevin McCarthy, I've got one online.
Okay, thank you. Who is that?
Kevin McCarthy.
Kevin, morning.
Good morning.
You're on.
Thank you. Mr. Beck, thank you. Appreciate the presentation and the information. I think I heard you say that there's a 50-50 split in bed days for those with mental illness and those without, as listed in Aegis. Did I hear that correctly?
Yeah, presently, and as we've gotten to 2022, the total bed days are seemingly split between those who have one of those 4 mental health indicators that I started this with and those who don't. Now, there could be lots of reasons for that. An increased use of caution codes, increasing willingness to self-report, as well as COVID itself with all of its trauma in some people's lives, how that's increased their use of the jail, or their interaction with the jail.
So then can we infer back to cost?
Yeah,
fundamental question is, are we 50-50 cost of housing folks in the jail is for those with some underlying mental health issue?
You could take that interpretation, and that's why I mentioned at the start of that slide that this is the one that would interest Cassie. Because as you're paying the bills, if there's a way to decrease mental health, if there's a way to lessen the interaction, lessen the frequency of interaction of those with mental health issues and the jail, to lessen that interaction, you are likely to reduce bed days for that population, which then, the jail has fixed costs, which aren't going to change. You have to keep the lights on. But there could be a savings or a cost efficiency, according to Susan. Yeah.
Thank you.
Okay,
Yeah.
thank you. Any other questions? Mr. Beck, thank you. Always appreciate seeing you and the information you give us and your efforts. Thank you. We'll go on to item 5 on our agenda, community updates. First is Kevin Richardson is reporting to us remotely. Morning.
Yep, that's correct. Are you able to hear me?
Yes.
Perfect. So just providing some brief updates. I'll keep this as brief as I can because I know there's still more on the agenda here. With PATH, everything is incredibly busy here. As most of you are aware, we earned a large grant last year to provide 988 services, which is an expansion of what was previously the National Suicide Prevention Lifeline, to essentially the entire state of Illinois. We are primary coverage for 85 counties in Illinois, and we are backup coverage for the remaining counties. And so we, in January, handled over 8,600 calls from the 988 line alone. So we are continuously hiring. It's been quite the culture change. We used to be a relatively small agency that was primarily volunteer driven when we were handling our calls. I've been with PATH for almost 10 years now. So, I've seen what we looked like before and what we are transforming into. And so that comes with its bumps in the road. It's an entirely different ballgame at this point. And so one thing that we are doing as the primary 988 provider in the state of Illinois is we are meeting with the state of Illinois weekly. There are 5 other 988 centers here in Illinois. One's in Springfield. The other 4 are up north in the suburban area in Chicago. And we are by far the largest provider by about 30 times of any other provider. And so we sit on plenty of these CESA meetings as well. And the state has asked us to have representation on all these meetings because it will directly affect how 988 functions, how it's intertwined with the mobile crisis intervention teams. Because 988 is truly just the first step in a full statewide crisis continuum, is the ultimate goal. Now, the state has indicated this is going to be a 5-year effort. And so that means it's probably going to be a 7 or 8 year effort in all practicality as we expand and ensure that all these systems. So a lot of the things that we're discussing for McLean County are also being discussed on the state level, and that's informed by legislation, and it's divvied out by what are currently the 11 EMS regions as well when it comes to CESA. And so they're discussing how each region will have their own sort of rules about how things go. But there's also a universal type approach. And so what the biggest issue right now is with the state and continuing to develop the behavioral health crisis continuum is how do we account for the vast differences in culture, in population, et cetera, not only from region to region, but even within regions. They're calling them sub-regions at this point. McLean County is in the same region as Peoria County, and we function very differently. And so it's, essential that the state gets this right. But I think it's really important, at the end of the day, my conclusion, it's really important that we are paying attention to what's going on with CESA and what's going on statewide, because whether we like it or not, the state is moving in this direction, and there's clear legislation. I'm sure there's going to be amendments to that legislation. It's going to affect McLean County, but it's going to affect everyone statewide. And I can tell you that the ultimate goal is something like a closed loop system. So when someone enters the behavioral health system, whether it's through the jails or through 988 or through a hospital or what have you, ultimately the goal is probably 10 years away, at least with the entire state, is to have this sort of closed loop system similar to what we're discussing here. And so in a lot of respects, McLean County is very much progressive and is already taking a lot of the steps, and has already taken a lot of the steps that the state seems to be moving in the direction of. And I do want to also share all of these meetings for CESA are publicly available. They're on Illinois' DHS website. All of the recordings of them are available as well. McLean County is in Region 2, but there are also various statewide committees. I know Susan Schaefer at least has been attending some of these as well. And so I'm sure she has thoughts as well on how some of these are going and how McLean County specifically will be affected. But again, I don't think I can emphasize enough how important it is to really be aware of what's going on with CESA as that continues to evolve.
Okay, thank you. Are there any questions for Kevin? Anyone? Yeah, Stephanie?
Hi, Kevin. Thank you. Quick question on, and I know locally here in McLean County, you've been instrumental in working with the crisis team for McLean County and our SAS team in ensuring that, youth and that process has not been really changed by 988. But on the larger scale, on the statewide scale, is there any conversations yet that you're aware of talking about the use of the CARES line and ensuring that youth that are eligible for crisis services through SAS CARES aren't getting lost in that system or aren't getting sent to the regular crisis teams?
Yes. So, and I want to clarify too, I do not speak for the state, but we're a third party vendor of the state. But I can tell you, based on the discussions that I've seen, that is a point that is being discussed. As far as I can tell, there is no intent to lose the SAS program. There are a lot of differences, key differences, specifically billing and insurance with SAS that is just fundamentally different from what a mobile crisis intervention or even a co-responder model would look like. And they certainly recognize that. Now, where that will be in a year, your guess is as good as mine, but it's certainly being discussed.
Thank you. Good to hear.
Okay, thank you. Thank you very much. We'll move on to a report from Carl. Teresa Prosser, morning.
Good morning. All right. So just put together a little bit of an update. I'll start with outpatient first. We were fortunate over the last 9 months or so to be able to secure 2 adolescent psych providers, which for Carl was enormous. And I think just for the community, sorry. Is that better? Thanks, guys. Okay. All right. Both of those providers are actually doing their sessions virtually. And then we also have a APP, so a psych nurse practitioner that works with that group, and she sees patients in both virtually and in person. And one thing that's a little bit interesting about that is we thought that the virtual would be like gangbusters, and not as much is what we thought. So just seeing that people, especially when you think about the parent piece or the guardian piece with the adolescents, they really prefer at least that initial visit to be in person to establish some kind of a relationship, which I feel like virtual is awesome, and we learned a lot with COVID to be able to do that and kind of go out there. But it also kind of makes my heart happy that people still value actual connection. I'm just going to throw that in there. So we do have some partnership with United Way to do some things within the schools too for adolescent psych. For inpatient, we have, I don't know if anybody recognizes the name of Dr. Imman, but she's been in our community within Medical Hills, and she transitioned over to Carl outpatient. We have an additional psych provider that is coming in probably August or September, and he will be outpatient primarily, but helping support inpatient from an all-call perspective. And then we have an inpatient psych mid-level that's going to start in August too. And so part of the reason why I'm saying that is we've been so stagnant from being able to secure providers for a long time. It's just, we're ecstatic about it. And having that APP come from an inpatient perspective, she is going to help us be able to expand our inpatient bed census. So we'll be able to go from 13 to 19, which will be a huge help. And then also longer term goals with that is to be able to expand both partial hospitalization, intensive outpatient, and aftercare, mirror kind of what we do on the addiction side of things for our mental health population, and be able to work towards that too. It won't happen immediately, but that's kind of in the works for the future. We are trying to do things a little bit differently, where we are meeting patients where they are at. And when I say that, I mean more within Carl. So if we have a long-term patient in ED, or we have a mental health patient that is in our ICU for whatever reason, providing them not just the psychiatric services from a physician perspective, but also behavioral health services, and trying to get some of those things implemented sooner than later. We also started providing behavioral health services at our Cancer Institute last year, and that has been really successful too. So addiction side of the service line, we added an APP last year, so we have inpatient detox, we have up to 9 beds, and then we have the partial hospitalization, intensive outpatient, and aftercare. Both of those programs are actually growing, and we've seen really good success with that. Our MAR is expanding, so we are going to actually move that into its own kind of clinic suite within Carl, which is really exciting because we'll be able to have additional access for those that patient population, client population, and then we're also embedding behavioral health therapists into that clinic for them, so they will be able to have that support as well as the MAR piece from the physician APP, and their family or support system, adult, not adolescent, will also be able to take advantage of that. So the goal is to really start setting them up for success. And looking at things like not just treating their mental health or their addiction, but helping them establish a primary care physician if they don't have one. Helping them create an advanced care planning document so they have a power of attorney for healthcare if they become non-decisional for whatever reason. Making sure that they're set up for either Medicaid or Carl financial assistance, because we may have them for one touch point, but then the next day they need I don't know, they have a cold and they need antibiotics or whatever, so really helping the full continuum of care, kind of look at things a little bit differently. We do have one Carl crisis worker in our ED. We are trying to hire for another one. when I say trying, it's been a year and a half that we've been trying. So, we feel that pain, but we're still well supported by our county, crisis workers too.
Teresa, what is MAR?
Medically assisted recovery. So MAT is the term. It's kind of moving to MAR. So like Suboxone, people that require medical prescriptions to help with their addiction.
Okay,
Yep.
thank you.
Yeah, no problem. Thanks for asking. We are trying to partner a little bit more with Urbana, Carl, all of Carl. We're trying to work as a system, if that makes sense. And I know that may sound strange, but we're still working on it. It's been a couple of years, and then we've got Unity Point Methodist coming on in April. So that adds a whole nother layer of complexity to things, but exciting. U of I started a partnership with Carl for psych residency program. So we've got some of those residents spending some time with us, and hopefully the goal is even if they don't stay with us, we can attract them to the community. It's trying to think about things not just like us, right, Carl, but how do we bring them into our community in general? Same thing for APP providers from a psych certification perspective. Because being a nurse, and there are a lot of nurses going into practitioner school roles, and there's not a lot of jobs, right? So they're looking at more specialty areas, which I think is a good thing because I think that will help us, down the road. Continuum of care is a big thing. I know you guys talked about the EMR and the data, and I'm just gonna say a couple things about that. It is incredibly difficult within healthcare, especially with the mental health code. I think, from that standpoint, to the point that we struggle even with our own family, if that makes sense, where if we have patients that are seen within either our mental health unit or our addiction recovery unit, we may have a Carl primary care provider, they can't even see that information because it's so protected. So we feel that pain even within our own constraints, but I do agree there are things that we can do. We've tried to open access up to just, even within the medical community, HIPAA, all of that. But I do think we can get there, and that is one of our biggest barriers. We can give numbers, right? We can give patient census numbers, but to really drill down and give data or to say, this person was here yesterday, they're here next week, and they were here last month, we can't do that. And it's not that we don't want to, so I just please know that. At least at Carl, we're very willing to try to share. So, and we see the benefits too. Future things, we're looking at partnering with Carl and Urbana for TMS, for depression, and then also starting ketamine clinic in our area. So lots of things. Not right away, I know, but we're gonna get there. Yeah, so planning stages. Just appreciate the partnership.
That's a lot of good news. Thank you
It
very
is.
much.
We still have a lot of, it's a lot of work, but I think the biggest thing is people, right? Like providers or, therapists. I think there's a lot of good ideas. It's just, you got to have the people. So, thanks, guys.
Thank you. Are there any questions for Teresa? Okay, thanks a lot. Appreciate that. We'll go on to McLean County Center for Human Services, Joan Hartman. Joan, are you on?
I am. Thank you very much, Chairman. I just wanted to give a brief update, letting you know that at our urgent care, behavioral health urgent care, we had an open house last week, which we had great attendance on. This is in our new space that we have created in our Tower Center at 520 North Center Street. And we had about 65 individuals who came through that space. Were very excited about the services. And a lot of them were other providers. We had individuals from private practice medical offices come and visit. We sent them back with our cards that indicate how they can send patients to us. Our plan is to have our coordinator and Kim, our clinical director, go out and meet with various groups, including medical practices, to give them more information and keep them supplied with the cards that they can then give to patients. We still are struggling with hiring staff and have tried numerous ways to increase our applicants. We currently, as a matter of fact, last week during the open house, I was a little late coming to the open house because I was meeting with Northern Illinois University's nonprofit studies department because they will be partnering with us to develop a staff recruitment and retention plan. So we're excited about that and to see how they can assist us with that. Marketing, we have our plan developed. It started a little bit this month with some interviews with the Pantograph and with WGLT and some social media. We also are planning to expand it significantly in April with a multimedia approach, including online advertising, some geo-tracking, geo-fencing, billboards, bus ads, printed materials, website enhancements, and we're looking into a couple of other options too, including like bus stations, not the buses, but where people wait for the bus, and the train station. So I think that's all I have for you today.
Okay, thank you. Are there any questions? Joan, more outreach, the better, I'm assuming, on this, getting this going. Have you had any interaction with law enforcement?
We have, as a matter of fact, we've shared information with the police departments, and Kim has scheduled a meeting with Bloomington's EMS because they expressed an interest in learning more about the program. So those will be things, Chairman, that we will do on a regular basis because we know that sometimes out of sight is out of mind. And so our plan is to go regularly, just like our mobile crisis team does, to share information and talk about any issues that may have come up in terms of how they feel about, or any things that have happened that we need to process through, fix maybe some glitches or whatever as we continue forward. Oh, I forgot to let you know also that the state has issued a notice of funding opportunity for the living room. And that grant application is in the works by our grant writer, and we will be submitting that at the end of the month. They say they plan to fund between 25 and 35 around the state. So our goal is to obtain that funding so we can have a discussion with the county about releasing the funding that you're currently giving us.
Okay, well, thank you. Appreciate that. And we'll look forward to adding hours in there as soon as you can get some more people working for you. Thank you. Let's go on to item 6. Kevin McCall, I'm going to turn this part over to you as we talk about some initiatives.
Yeah, thank you very much. I know we're extremely pressed for time, so Sarah and I are going to go through these updates for our internal department pretty quickly. I will say that I will hang around if you have any questions, and I'm more than happy to meet with you on an individual basis if the conversation is a little bit more lengthy. So I'll let Sarah start with our first 2 updates.
Okay, so our first is some updates on the FUSE program.
Yeah, get right on it.
So since January 1st, we've had 2 clients obtain employment, both of them very excited about that. In February, we had a FUSE client obtain housing, which we are very excited about. Everybody knows the housing difficulties we've had in McLean County, and this individual has been looking for a very, very, very long time. So that's a major win for FUSE. As of now, there are now 15 clients. We added 2 in December and 1 actually just last week. So total of 15, there's been 25 in total since FUSE began 3.5 years ago. Since January, there's only been 2 contacts. For a context, the current 15 clients, when they first came under the program, there was a total of 120 contacts within the community. And within the past 3.5 years, those 15 clients, there's only been 32. So that's down to about 25% of what it had been. Moving on to Rise. We just finished up the first year. We have a 5-year plan, the first being to build a foundation. We developed 2 subcommittees. One is a training and development subcommittee, and the other is a data and metrics subcommittee. The data and metrics has developed a couple of infographics that we're starting to put out. I'm very excited about that as we move into the second year, which is to initiate community awareness. The training and development subcommittee has started putting together a master training, starting to put together what it looks like to find trainers and outreach to those that are interested in learning more about trauma-informed care within the community. We're also starting to build our online presence. Very excited about that. It'll be through the county website, and that should be up and running within the next 2 months. And I think that's all I got.
All right, thank you, Sarah. The next item is the SOC grant that we've been working on, and I'm happy to say that this project has been an absolute treat for me compared to some of the other grants I've had in the past. The excellent framework that we were provided from Tri-West Consulting, as well as the expertise of the organizations that we have involved on this grant, has made it an extremely easy process, and we should be ready to fully submit our application by the middle of next week. We have a due date of March 21st, and so leaving a couple of days in there in case there's some technical difficulties, which tends to be the more laborious part of this, is actually getting it all uploaded online appropriately and checking all the appropriate boxes. And so I'm hopeful that in the next few months here, we'll hopefully get some idea if we're going to get this grant or not. And so I'm extremely excited. Our partner organizations will get contact from me probably about 1 or 2 more times before we actually submit towards the middle of next week. But it's been a great project, and it's been a delight to work with those organizations as well. The last item here is our mental health action plan work groups. We are currently running our crisis and youth work groups, and I'm happy to say that we have had tremendous buy-in from the community, not only in just those meetings themselves, but also in other meetings I've had around in the community. You'll see individuals like Teresa Prosser and Kevin Richardson, who have given community updates on some of their things today, have been intimately involved in those groups and sharing information as they can and providing their expertise to move those forward. Both our youth and crisis groups are ready to move into their 3rd meeting, which is going to start to involve some of the wider community, some of those individuals that aren't explicitly BHCC members but have importance to those groups. For example, law enforcement, EMS, all of those types of folks are connected to our crisis system and therefore integral in having any sort of conversation about the crisis system. And so we'll be roping those folks in and having broader conversations, and finally taking some actual bites out of those goals and getting some work done in this community. I'm also happy to announce that we'll be rolling out some of our other work groups related to the mental health action plan here within the next week or 2. Those will be our housing and our access to medical services groups. I would encourage you, especially our BHCC members in the group today, to look at those sections to see which goals are in there and start to think about if you have interest in participating in those groups, what your role might be, and what other sort of goals and things are being worked on or worked towards in this community that relate to those groups. Thank you all for your participation in BHCC in general today and getting up early to come to this meeting and hanging around for an extra 5 minutes. I really appreciate that. Thank you very much.
Okay, thank you, Kevin. Our next meeting is Friday, June 9th. I hope 7:30 is still working. We originally established that meeting date for people so they could get to work, and because we appreciate all the time that's spent from that. So I hope we can continue that, and I hope we can get everyone here to have more interaction as we go through other items for discussion. So, again, welcome, Esteban. Appreciate you coming and joining us. Look forward to a lot of input that you can give us and what State Farm's got going on out there at times as well. Anyone else have anything? Member Schaefer.
I was gonna say, if anybody has anything that they'd like more information on what I talked about, please contact me because there was a lot of information that I didn't cover. And if you have questions that come up later that you think of, thank you.
Likewise, I'm hoping we can get a large group of people involved with these work groups from out the community, similarly to what we had when we first started the Mental Health Action Plan years ago. Thank you, Sonia.
You've heard me say this before, but I'm going to ask one more time for everybody to be sensitive to the use of acronyms.
Yes.
I look at Esteban and I think, oh my gosh, you're sitting here and swimming in this whole sea of APPs and EMRs and CMSs and SOC. I don't have any idea what that is. So please, please, when you make your reports, make them so that you say the name clearly and not just the acronym.
And Esteban, I have been writing notes so that I can meet with you afterwards to
Yeah.
fill you in on all
Well,
those.
thank TVM to you, and that I just made that one up. Thank you very much, Sonia, for bringing that up again. Anyone else? Yeah, Matt?
Thank you, Mr. Chairman. Really briefly, in case people hear about this, Chestnut, 5 other agencies in the Illinois Primary Health Care Association has introduced House Bill 2838, which looks at staffing in behavioral health across the state of Illinois. This bill is sponsored by Lindsay LaPointe, Representative Lindsay LaPointe. It passed unanimously through committee yesterday, and will go to full vote. Essentially, this bill will give tuition waiver for anyone interested in working in the behavioral health field in Illinois. That rises from certification level degrees all the way through graduate degrees. It's 4 years of tuition waiver if they commit to 4 years of working for not-for-profit in Illinois post-graduation. So if you hear about it, enthusiastically support it because it goes to definitely the staffing issue that's been brought up multiple times today.
Thanks, Matt. Very much needed. I know that. Yes, please.
I just wanted to add on, Matt and Dave actually reached out to me and wanted me to share that at this meeting, and it wasn't officially on our agenda, so I appreciate Matt bringing that up. I will share that official House Bill PDF with everyone in BHCC. It is certainly something I think all of our partner organizations are going to be very interested in.
Okay, well, thank you very much for coming. Have a good weekend. We'll see you next time around. Keep in touch with everybody, and we'll adjourn this meeting. Thank you.